Well, good morning, everyone. I was hoping everybody would have coffee and could kind of sit back and relax while I changed the topic a little bit from yesterday. I think when the organizing committee came up with this topic, we weren't sure how many of our innovators of new tuberculosis therapies would be able to join us. And what's really exciting is that a lot of the actual clinical development of long-acting formulations for tuberculosis is going to be presented later. So I wanted to take this opportunity then to shift a little bit, just to reframe kind of our thoughts from antiretroviral treatment and prevention to tuberculosis and some of the other diseases that we're going to talk about later, and then also offer a little new data on patient and provider preferences around TB therapies. So most of you are probably aware in the room, but just to shift a little bit, so TB disease remains one of the leading causes of death worldwide and is the most significant cause of death related to infectious diseases. So it remains an incredibly important topic that causes a vast amount of morbidity and mortality globally. The standard regimen for treatment of active tuberculosis was a rifampicin-based regimen, so RHCE, for 2 months, followed by isoniazid and rifampin for an additional 4 months, and that was the regimen since the 1970s. So it's a long-standing, it's been around a long time. Probably some areas for improvement. Fortunately, in the last few years, we have one option that shortens treatment a bit. Still 4 drugs for the first 2 months, followed by 3 drugs for 2 months. But still an improvement. We know that shorter treatment leads to better treatment completion and better treatment outcomes. I'm just talking about drug-susceptible TB. We know that therapy for drug-resistant tuberculosis is often much more complicated and requires a much longer duration of therapy. I've borrowed this slide kindly from Eric Nuremberger, who gave an excellent presentation at CROI, who really highlighted some of the opportunities that we have to improve TB treatment, particularly related to long-acting therapies. So despite having therapies and an ongoing research area or ongoing development in the area of tuberculosis, adherence, it remains a challenge, even with a 4-month regimen, and adherence declines substantially over time. So a huge amount of our resources go into programmatic methods to help support patients through adherence to tuberculosis therapy. And we know that because we know that unfavorable adherence leads to unfavorable outcomes. We do know that shorter regimens improve outcomes, and we hoped that long-acting therapies could help us do a better job delivering a patient-centered approach to TB care. So Eric outlined a couple of different options for how you would transition from an oral tuberculosis regimen described in the red in the bottom box there to potentially incorporate long-acting therapies. One would perhaps be to continue with an oral continuation, an oral intensive phase or an oral lead-in during a period of time where the patient may be most ill, and then transition to a long-acting product for completion of therapy. Or kind of the holy grail would be a long-acting product that could be given, let's just pretend we could give it once and be done with treatment. And then there's a whole spectrum of other ways that long-acting therapies could contribute to these options. So along with the spectrum of options for treatment, there's also a significant spectrum of disease related to tuberculosis, ranging from TB exposure that could establish a latent tuberculosis infection, or active disease that we were talking about with the former regimen. There's lots of patient-specific characteristics and conditions that could lead to a higher rate of development of active tuberculosis. So a huge area of focus is also TB prevention therapy. And that's important because we know that we estimate that about a quarter of the global population lives with latent tuberculosis infection, and there's ongoing exposure to TB due to inadequate treatment elsewhere. So there's a huge role for prevention therapy, both for those individuals and those who are exposed to tuberculosis elsewhere. So here's a description of what TB prevention therapy looks like today. Again, for really up until the early 2000s, we were looking at a 6 to 12 month regimen of isoniazid. And so a huge amount of change where we have worked to shorten the duration of TB prevention therapy. Most recently, we have a 1 month daily rifapentine plus isoniazid that has been recently given conditional approval by the WHO for treatment shortening of TPT. But for the most part, we're still looking at somewhere between 6 and 3 months from a global perspective. So we know that TB preventative therapy works, but we also know that completion is poor. And this is a meta-analysis that was published in 2016. So this is mostly looking at those longer TB prevention regimens. Only about 30% of people who were eligible for screening for TPT ended up accepting and starting treatment. And then of those, only about 20% actually completed therapy. So again, a huge opportunity to remove some of the barriers that exist to completing TB therapy, including side effects, length of therapy, and just some competing priorities for people who would benefit from TPT. So again, is this another option where we have a smaller number of drugs, shorter period of time, where you could really see a clear path for the benefit of a long-acting TB product? What's exciting is right now we have, at least according to this study in 2024, or this commentary in 2024, there's about 18, probably more now, new products in the pipeline for TB drug development. And that's a huge change. You know, there was this burst of activity in the 40s through 60s, and then really a lull over, unfortunately, too long of a period of time. And the good news is that we've seen a resurgence in investment and development in this area, and I think we have an opportunity to harness that in the development of long-acting therapies as well. And indeed, that's what's happening by many of you in the room. Again, I'll refer you to Eric's Croy presentation. He did an excellent job of summarizing where we're at with long-acting therapies to date. And then we're going to hear some new data today from others in the room. So I'm not going to go into the specifics about these, but I would refer you to this online presentation and look forward to the presentations later today. I've listed those products that I knew of, but I also know that there are many more products that are perhaps in preclinical or not yet widely available. So we look forward to hearing about more TB long-acting agents in development. So here's another area that I feel like we've touched on a lot, and so I just wanted to highlight a few of my thoughts around how things we've talked about already or we'll talk about later today maybe impact on TB long-acting agents. I think we have to think about how potency and what kind of PK targets we have impact our drug development. And fortunately, we're going to hear a wonderful presentation by Rada Savik just after this, so I'm not going to talk a lot about what we need to know about PK targets or what we currently know. But I just wanted to highlight that every drug is going to have a different target. And when we talk about something like a contraceptive implant that can last for many years, we're looking at a PK target of somewhere in the low picograms per ml. So you're able to have an implant that can last for that period of time because of that low target and that high potency. Antiretroviral prevention products that we talked about yesterday have a bit more of a range, whereas lenacapavir is more around 15, or the estimate is 15 nanograms per ml, whereas cabotegravir is around 600 nanograms per ml. The cabotegravir is similar to the target being used for rifapentine that's being developed through the Longevity Project at the University of Liverpool. And so that kind of tells you that we're probably far from having a rifapentine implant that we would be able to use, but you could see a very nice correlation between the cabotegravir intramuscular injection and rifapentine for this product. There's important considerations about regulatory pathways, and I think we can really leverage what we heard from Kelly Reynolds yesterday about the cabrolpivirine process. And I would refer you to a great resource on the LEAP website that was a LEAP and CELT co-sponsored activity on the workshop of bioequivalence, and really thinking of new and innovative ways that we can help use bioequivalence to support long-acting development. And then I was thinking yesterday as we were listening to Kelly Reynolds talk about gabapentin, I don't think we need to wait for us to have the perfect drug in order to go into product. We saw a lot of regulatory changes for both CAB and gabapentin after the initial regulatory approval. We saw a removal of the oral lead-in. We saw adjustments to dosing. We heard with lenacapavir, we heard changes of the oral lead-in based on modeling. So I think we just need to keep moving forward and realize that we can make adjustments down the road as we learn to use these new tools. So that's the overall LA pipeline. And then again, I'm excited to say that we have a very robust LA TB pipeline for the rest of the session here today. So I look forward to hearing the rest of these presentations to further this conversation. For the rest of the time, I wanted to shift to some recent data that have really tried to quantify and describe end user preferences and values related to a long-acting TB, either prevention or treatment product. As we've heard from the antiretroviral PrEP space and contraception space, this is an area of robust activity in that area. But these data are really kind of new in the area of tuberculosis therapy. So just hot off the press, about a week and a half ago, we have a publication from the Longevity Group that conducted an in-person survey of just over 400 end users in India and South Africa. So these was a patient survey. I'll probably refer to them as patients here throughout. And then we also did an online survey of nearly 100 policymakers or healthcare providers across the globe. So first and foremost, you hear a lot about there potentially being some resistance to injectable tuberculosis therapy because of the history around injectable aminoglycosides and the toxicities that were associated with that in drug-resistant TB therapies. So first and foremost, we just wanted to find out if this was something that patients in this survey also had a challenge with or felt like this would be a barrier to use. And really what we found is we did not see this in this particular group of 400 end users, of which many had prior experience with either TB treatment or prevention. Nearly 75% of them would prefer a long-acting injection. We saw less excitement about the patches or the microarray patches, as well as implants. And we really attribute this to perhaps just lack of knowledge or understanding around those products. They're just not widely available or used globally. So I think if those are products that move forward, we're just going to need to think about how we're going to engage the community and educate on those products. Within the long-acting injection, I think we also made some assumptions that people would all want a one-shot and done related to tuberculosis prevention therapy. And interestingly, we found that of the choices we gave them, which was a one-time only, one shot every 2 months, one shot every 2 weeks, one shot every 2 months, very far. Once a month for 2 months or once a month for 3 months, we saw really high acceptability across those, as you can see in the blue bar. And actually the most preferred product was once a month for 2 months. And some of the feedback that we got around that was we did see differences between the sites where this was administered. So I think it's important to think about the setting, and not every patient and not every setting is going to have the same desire. But there was a strong preference for kind of a need to come back and make sure that you were okay and have that touch point with a provider. So although we may think it's really important to have a one-shot and done regimen, and although that would be great from a programmatic perspective, there are still some needs for the patients and the providers to have that ongoing touch base. Patients perceived lots of benefits to injectable prevention therapy, really high rates across everything that we asked, but primarily they felt it would be easier than a daily oral pill. There is a perception among our respondents that it would work better than oral therapy, even though we told them that it would, to assume that it would be the same. And there was an opportunity for more discretion. Shifting to the providers, we asked them in general, if it was improved and the efficacy, safety, and costs were the same, would you use a long-acting product? And as you can see here, by and large, that was a positive response. About 40% said yes, they would use it for all participants, and a slightly higher percentage said that they would use it for people who they thought may have a barrier to TPT completion. They also had a preference for injection, although maybe not quite as dramatic. We did offer oral pills as an option, and that was their second choice, followed by implants and then microwave patches. Again, just an opportunity for awareness about some of these new formulations. Next, we asked providers what factors would influence a national health program to uptake a new TPT program. And I would say, no surprise, the biggest barrier was thought to be the cost of the medication for the National Health Service, and then other concerns about just longer duration of side effects and increasing needs related to provider training. But they did recognize that the health service would preference them if there was higher quality of life, patient satisfaction, and improved efficacy. Next up, I want to shift to a poster that was just recently presented in Vancouver, looking at using a two-stage mixed methods approach in one country in the Philippines. So I learned about this at lunch yesterday, so I wanted to add in a few slides about this. They did a first stage of 15 stakeholders with in-depth interviews, and then followed that up with a larger survey of patients and providers using a mixed methods of discrete choice as well as a survey. One thing I thought was interesting is they first described different scenarios similar to our question about compared to the standard, would people prefer either having one injection, so 4 injections at one time to provide treatment, 2 injections monthly for 4 months, or a 1-month daily oral lead-in, and then 2 injections every 3 months. And I think relatively surprisingly, we saw a similar story here where the provider interviews really felt like that ongoing touch point was important, and they preferred the 2 injections every 4 months without an oral lead-in period. Shifting to when they looked at the broader group, it's a busy slide, but basically the same question about either the basic scenario or the standard scenario in the top, and then each of those 3 scenarios below. And you can see that the one and done, sort of 4 shots at once, was the least preferred of all of the options. And that came out in their discrete choice experiments as well, where they identified some significant things that may deter participants from wanting to have the long-acting product. And one of those was having 3 or more injections at an individual visit would decrease the priority for a long-acting product. Injection site pain, and also location of the injection was important to the respondents for this as well. So all of these things give us important characteristics that we need to think about as we move forward with the development of anti-tuberculosis long-acting products. So in general, I think, I hope we all can agree that additional new long-acting TB drugs that are accessible and affordable globally are still important. We have a long way to go to improve both TB treatment and prevention. On the other hand, we're living in a very exciting time. Really not in my lifetime have we had this many drugs that are on the forefront and maybe coming out. So we have a great opportunity to leverage that into long-acting development. And I think it's important to just remember that we need to, in parallel, move forward with provider and patient satisfaction and value surveys to move forward. Just want to give a shout out to the LEAP website. It has a lot of great resources also related to tuberculosis. We have a tuberculosis working group within there that I would highly recommend reaching out if you have an interest. And then I just want to close by thanking all of my collaborators, people who helped share slides, either knowingly or unknowingly, and all of the people working on this TB drug development. So thanks very much.